All right. So I believe we'll start. So I hope you're able to hear me clearly. So we'll put the slides up. All right, so we'll start. So thank you very much for joining us today for our 8th series of our weekly webinar. So today we are tackling a topic on H. pylori. So we are looking at other diagnostic approaches on diagnosing H. pylori that are quite accurate and precise. So I think over the years, we've relied on the stool antigen tests for H. pylori. And at times we get a lot of false positives or maybe false negatives here and there. But the false positivity rate is quite high when we're using the RDTs because we've not been able to standardize our RDTs ecosystem. So with us today, we have Jessie from Headway. He wants to take us through the Urea Breath Test as an alternative for H. pylori testing. And with me, we also have our organizer, Haroun, and other team members that are on this technical side. So without much further ado, my name is Antony Jaccodul. I'm the moderator for this session. And I'll hand it over to Jessie so that she's able to take us through the Urea Breath Test technology. So over to you, Jessie, unless Haroun has anything that he wants to say.
No, thank you all for coming and attending on time. So others who are joining will find us on the way, as we always start exactly on time. So with us, our presenter is Jessie, sales manager for Africa for Urea Breath Test. She'll be able to take us through the history of H. pylori and her offerings on UBT as a gold standard for H. pylori testing. We also have Leo, manager at Headway. Jessie will be able to introduce her. So as she's setting up her PPT on presentation mode, Jessie, you can start. Thank you.
Hello everyone. Can you see my presentation?
Yes, the presentation is visible.
Okay.
Kindly put it on full screen mode.
Now it's a full screen model. So shall we begin?
Yes, let's start.
Okay. Okay, good morning, everyone. Thank you for taking time to join today's meeting. My name is Jessie. I'm a sales manager in Headway company. Our company is the leading supplier of urea breath test product. So it's a great pleasure to cooperate with our director, Mr. Leo, and our partner, Keton Group, to conduct today's CME. Today we'll be focusing on diagnostic approaches to H. pylori, implementing the urea breath test in clinical practice. We are going to explore why H. pylori remains an important clinical concern, review the available diagnostic method, and discuss how the urea breath test can be effectively introduced into routine practice. This will be an interactive session, so please feel free to share your thoughts or any questions. Okay, in 1982, Australian scholar Barry Marshall and Robin Warren isolated H. pylori from the gastric mucosal specimen of a patient with gastritis and peptic ulcer. It reveals the complicated relationship between gastrointestinal diseases and Helicobacter pylori. So, about H. pylori. H. pylori is a gram-negative spiral-shaped bacterium that colonizes in our stomach lining, causing stomach diseases. The symptoms include bloating, burping, vomiting, and pain, and other symptoms. In 1994, H. pylori was clarified as Class 1 carcinogen by WHO. It represents a key factor in etiology of various gastrointestinal diseases like dyspepsia, chronic gastritis, duodenal ulcer, peptic ulcer, and even gastric cancer. So, how does the H. pylori attack our stomach, and why do we need to eradicate H. pylori early? The normal mucosal progress to chronic superficial gastritis and chronic atrophic gastritis under H. pylori attack. Eradication here, this stage, can prevent partly intestinal type gastric cancers, but once it advances to intestinal metaplasia, the stomach lining undergoes irreversible changes. Even post-eradication, the cancer risk persists. Therefore, most of doctors suggest the primary prevention is eradicate H. pylori before atrophy and then follow up regularly. Okay, this is the global prevalence of H. pylori. H. pylori affects near 50% of the global population. 70% was found in developing countries and 30 to 40% in developed countries.
I think your slides are not moving, Jessie.
Hello?
Hello, your slides are not moving.
Not moving.
Yeah.
这 PPT 没翻译，我当时也是没翻译。
Oh, wait a moment. Let me adjust that.
Yes, no, it's fine. Thanks.
Okay, this is a global prevalence of H. pylori. So next. The key factor contributing to the high prevalence of H. pylori is because its strong effectivity. It can be transmitted from person to person, like oral to oral, gastro-oral, fecal-oral, and even the infection by the endoscopy procedure. So this is an article published in 2024. It shows the prevalence of H. pylori infection in sub-Saharan Africa range from 24% to 93%, with Tanzania reporting infection rate range from 39% to 65%. And see this image. This image is show the H. pylori infection rate in countries of East Africa. The average infection rate in Sudan is 61%, while in Ethiopia, the situation is even more serious. Some study reporting prevalence as high as 72%. The lowest prevalence was reported from Uganda at 40%. Actually, these high rates are not just numbers. They reflect a massive ongoing health burden, especially in the regions where early screening and accurate diagnosis are still limited. So Japan is one of the few countries that has implemented nationwide H. pylori screening and eradication programs. The result has been remarkable. data shows that H. pylori screening combined with therapy has significantly reduced gastric cancer incidence and mortality in the Japanese population. This is an article published by Japanese scholars. Okay, based on this article, Japan has also defined a specific recommendation for screening based on age. It suggests that detecting children who are elder than 12 years old and do a massive screening after 20 years old. Currently, available diagnostic methods for H. pylori detection include both non-invasive and invasive. Non-invasive are carbon-14 and carbon-13 urea breath test, stool antigen test, serology test, and invasive methods include PCR, endoscopy, histology, culture, and rapid urease test. A study published by WJG, World Journal of Gastroenterology, it mentioned that endoscopy is an invasive procedure which is discomfortable and not suitable for patients with severe contraindications. Besides, cost of endoscopy and additional costs adding on endoscopy may be high. Regarding to the endoscopy operation, it required the trained staff and good equipped facilities. So most of primary health facilities cannot use endoscopy because their infrastructure is not good, is not well. This is an article compared the accuracy of stool antigen test and the urea breath test. Its conclusion is that carbon-14 urea breath test is more reliable than stool antigen test. Besides that, stool antigen test, the accuracy is lower for confirming eradication of H. pylori infection. It may lead to the misdiagnosis. This is a comparison between serology and the urea breath test. It proves that the sensitivity, specificity, and accuracy of UBT is better than serology. Moreover, serology doesn't identify active infection, so the serology it's not the acceptability is not very wide. Okay, the WGO mentioned that UBT is the preferred method for diagnosis of H. pylori before and after treatment. Its sensitivity and specificity are above 96%. Also, the world famous GI organization have made a high appreciation to the urea breath test, like AGC and Mayo Clinic and the WGO also point that urea breath test is the most recommended non-invasive method for initial checking and verifying the eradication of H. pylori infection. Evaluated across the accuracy, non-invasive, non-cross infection, convenient, time-saving, easy for operation, easy for sample storage. To evaluate the UBT in this matrix, UBT can meet all requirements, and that is a testament to its golden standard combination of procedure, safety, and efficiency. justifying its top-tier status in international guidelines. Okay, next, I will make a detailed introduction of our Urea Breath Test product. The working principle of our Urea Breath Test is that urease enzyme is not present in mammalian cells, so the presence of urease in the stomach is the evidence that bacterium H. pylori are present. So the patient just need to swallow a capsule labeled with carbon-14 or carbon-13. If the gastric urease from H. pylori is present in our stomach, the urea will react with urease enzyme and split to ammonia and carbon dioxide labeled with carbon-14 or carbon-13 as the interface between the gastric epithelium and the lumen. So the carbon dioxide labeled by carbon-14 and carbon-13 is absorbed into the blood and exhaled in the breath. So we use the bags or collection cart. We use the bags or collection cart to collect the sample air. After that, we insert the sample to our machine, and our machine will detect this sample. Then we can get a report. So what should we do before testing? The patient need to fasting 2 hours or better for overnight, and do not smoking within 1 hour before test. Keep your mouth clean because your mouth have many bacteria. It may affect the test. So for first installation, we need to do 3 steps: the adaptive environment, self-inspection, and stand card test. That is just for first installation or every time you move it to a new location. I will have a detailed introduction about how to do maintenance in the later slide. So the operation steps are even more faster. The patient just need to take a capsule with water and sit quietly for 15 minutes, and then blow into the collection cart for 3 minutes. After 3 minutes, we just need to put the cart into the measurement slot, and our analyzer will proceed test automatically. After 4 minutes and 10 seconds, we can get the result. During deal with the sample, we need to do some. We need to pay attention to the notice, like before inserting the collection card into the measurement slot, we need to peel off the protective film. And when we insert the collection card into the measurement slot, place in right direction according to the arrow on it. So, third, test the sample card with 2 hours if it is not sealed well in a foil bag. If we want to preserve it for 5 or 7 days, we need to put it in a single sealed foil bags without humidity and sunlight. After testing the collection, our machine will give a result automatically with the equipped printer. If we use the C value to judge if the patient is affected or not. If the C value less than 40, the HP is a minus. It means negative. If the C value higher than 50, the HP is plus. It means that positive. Besides that, our machine can connect the computer. If we can connect the computer, we will install the software, and by using the software, we can print the A4 formal report. In the formal report, we can add anything in it, like we can add some tips in it. If the patient is positive, we recommend you bring your family members to hospital for the double check, because H. pylori is a kind of bacterium with high effectivity. So in conclusion, our analyzer has 3 clinical advantages. Advantage 1, it is convenient. The patient can get the report quickly, and the operation is very easy, just a device and a test kit. Advantage 2, it is swift. The whole test procedure will take 20 minutes only, and the device can get results within 4 minutes and 10 seconds. And its result is accurate, reliable. The machine is intelligent, or it is intelligent with lower maintenance needs. So our UBT can adapt to various needs, such as hospitals, outpatient clinics, and screenings. In hospital labs, our machine, they seamless fit into the routine workflow, suitable for high volume testing and standard results, quick reporting. In outpatient clinic, our analyzer, a small meet the need for quick and patient can receive same-day results. No need to make several visits to hospital. In screening programs, it is the ideal solution for community health checks, school, company, and government screening programs. It can support large-scale testing for early detection. Our carbon-14 urea breath test system is cost-effective. Why we said that? We can see UBT is a high sensitivity and specificity for active infection and eradication confirmation. So you can avoid cost from false positive or false negative. And it can avoid the invasive procedure and avoid the endoscopy cost. As we all know, the endoscopy cost is higher. UBT cost is lower than endoscopy and even similar or slight higher than stool antigen test. And it can reduce the repeat care. The reliable results and post-treatment confirmation can avoid the misdiagnosis, can prevent prolonged antibiotic medicine treatment. There are 3 points to evaluate the accessibility of a urea breath test. First, the infrastructure. It just needs a breath test analyzer and a test kit, and even every medical practitioner can operate it. And the setup is a clinic or laboratory. Do not require GI rooms, and the results can be the whole testing procedure can be finished within 30 minutes. Enable same visit decisions and reduce the loss to follow up And the efficiency, our modern analyzer can handle more moderate to high volume efficient. So it is good for hospital outpatients and diagnostic centers, laboratories, and for large-scale screening programs. Also, it is widely used or widely accepted by patients because it is non-invasive and it is quick, and the test procedure is comfortable and convenient. Patient just need to do a single visit, minimal preparation, and well tolerated, like the children and adults and the elder can do such tests. Also, the patient prefer breath test because it do not need to collect the stool and do not need to do any invasive procedure. So let's have a glass on the comparison. Urea breath test is the perfect non-invasive method for detect active infection and detect eradication confirmation. Its accuracy is high, and the turnaround time is just minutes, 4 minutes and 10 seconds. And just need an analyzer and keys to finish such test. The patient acceptability is very high. To ensure the accuracy, we suggest that to do monthly maintenance. So how to do the maintenance? We have 3 steps. Step 1 is the adaptive environment. After switch on the power button, our machine screen will show the loading bar. Before the loading bar finish, we press the test. Our machine will enter into the adaptive environment automatically. It will take 41 minutes and 40 seconds to finish this procedure. After finish this procedure, our machine will print a report. And after adaptive environment, the device will proceed self-inspection automatically. It will take 4 minutes and 10 seconds. So finish both these procedures, our machine will give 2 reports. We can see the report has a background count. It helps us to judge if our machine is working in order. If the background count is less than 250, it means that our machine is working properly. So step 3, we to do the calibration, use the background card and efficiency card to run sample test. Each test will have a result with C value. The background card, the result should be always negative. It means C value less than 40. The efficiency card, the test result should be between 30% or minus plus of 30% of the indicated value. For example, the C value is 730. The efficiency card test result should be between 511 to 949. If all the results in the normal range, it means that our machine is okay, is ready to work. So to maximize the value of our urea breath test, doctors and patients also need to do some pay attention to the operate to avoid several misunderstanding. or misdiagnosis. We have sorted them into a list. For the patient factors, if insufficient fasting time, we must need to fasting 2 hours. If we didn't fasting 2 hours, it may give us inaccurate result. And the operation factors like incorrect blow-in collection card, improper force, or insufficient time blow-in. Both of them will lead to the insufficient breath sample. And the second, contamination of collection card. The collection card may have some residues. It may affect the results, like give us a false positive or false negative. And the third, improper sample storage. Like after collecting the sample card, we need to finish test within 2 hours. If we want to perceive it in a long time, we must put it in a sealed wells for your bags. Otherwise, it will lead to the breath leakage. So how does the UBT change patient management? Let's take a real case from the primary hospital. A 35-year-old patient with chronic gastritis present with current pain in the stomach, but no endoscopy can be performed due to the limited resources in a primary care setting. So the traditional methods like stool antigen, serology, culture, and PCR and other traditional methods take a long time to get the results. Among them, serological antibody test cannot distinguish the current infection and the past infection. So our UBT, the patient can undergo UBT after 2 hours of fasting. They get a positive result that is confirmed the active infection. So this allowed immediate initial of eradication therapy, avoid blind medication use. So that way can reduce the pain and the cost associated with invasive procedure and shorten the time from diagnosis to treatment. Urea Breath Test can offer healthcare facility and the patient more convenient for H. pylori testing. Urea Breath Test is a performed option when patient declined invasive endoscopy procedure and declined. Maybe some patients refuse to do an invasive procedure because their poor physical condition and the biopsy sample can lead to the bleeding or cross infection. So for initial diagnosis, urea breath test is the preferred option. Also, for follow-up treatment review, urea breath test is the best choice because stool antigen test and blood test, their accuracy is not good as UBT. So Headway, as a leading global UBT supplier, we can provide several advantages to share with you. Like we are the world #1 urea breath test supplier with both carbon 13 and carbon 14 product. Our technology is advanced, and our quality is can be assured, can be trusted. And we have a professional engineer team, an experienced sales team, comprehensive sales service. Headway Company is a state-owned company with over 30 years diagnosis experience in the global market. So we have a comprehensive strength to promote UBT, and we have over 50 million people are using our UBT. Faced with H. pylori, accurate diagnosis is the first step and also the most crucial step. We hope that today's sharing can help you understand urea breath test better, and we also look forward to working with more healthcare facilities in the future to help more people benefit from such advanced diagnostic method. So thank you. My presentation is done.
Okay, thank you very much, Jessie, for the powerful presentation and educative components of how Urea Breath Test can revolutionize how we look at H. pylori testing in our ecosystem. So feel free to unmute and ask your questions or raise your hand on the chat bar, and also just write your questions on the chat box or in the Q&A section so that we are able to have a discussion. So as earlier said, this is more of an interactive session, so you can be able to give out your opinions as much as possible. The floor is open.
Okay, so we look into Q&A. You can type your questions or you can unmute, raise your hand, and then you can be able to ask. If case you want anything to be repeated, you can also address. Thank you.
Okay, so we have a first question that is from Charles Monzia. How available is the test method in Kenya? So Haroun, do you want to pick up this?
Hello, Charles. The products are available. In case you want a demonstration or you want to inquire, you can reach out to us. I'll share with you the contact details on chat box. Just write to the email or give a call, and a sales representative will be able to get in touch with you. We'll be able to share with you the brochure or the document, but the kits are available. The machine is also available. So only two things are required: the analyzer itself and the test kits, which is just the cartridges or the cards that we are using for testing. There's no any other consumables required. and it's simple machine maintenance free.
So maybe Charles can also, I hope you're able to see the facilities from, and maybe you can also pick up his contact so that you can share with the sales team. The next question is from Rotich Nelson. Thank you, Jessie, for the good and precise presentation. What is the best sample of choice for urea breath test? So Jessie, you want to pick up that? Yes, Jessie?
Hello. Yes.
Yes, there's a question from Nelson asking.
The age limitation for this test?
The one for the best sample of choice for urea breath test. What is the sample that is needed?
The sample is air.
Yeah.
The sample is just breath. The breath from our lung.
Yeah. So Nelson, you just once you take the capsule, you are able to breathe or blow into the kit, and then from there on, the kit is put in the machine, and then it's able to be analyzed. So you don't need any stool, you don't need any saliva, you don't need anything else. It's just the breath that is blown into the kit, and then it is tested. So the next question we have from Philemon. I wish to know the age limits for this test. What is the lowest age? Can it be used in children? Can it be used in the elderly in that particular forum? Jessie, you want to answer that?
Yeah. Okay, thank you. Actually, for the age, our urea breath tests are suitable for children and adults. But for the children, the teenagers, the age, who are not above 80 years old, we do not suggest them to do the urea breath test, because if the patient is positive, we need to do the antibiotic treatment. So the antibiotic will affect the grow up. So we don't suggest them to do such test. It's meaningless.
Okay, so the children of what age? So what is the age like limit for this particular test? Do you need like a child of 2 years and above, or 1 year and above, or how is the age like? Or anybody can be able to do it so long as they're able to breathe into the card?
Maybe
Excuse me.
Yeah.
This is Leo. Yeah. Let me explain. In fact, all the children can do the test if the children can swallow the capsule, because some children with very young age, maybe it's very hard to swallow the capsule. So if the children can swallow the capsule, then the children can do the test. But normally we don't recommend the children or pregnant women to detect H. pylori, because even it has been confirmed H. pylori positive, the treatment of H. pylori need to take medications like antibiotics and PPI, and antibiotics maybe need to take 2 or 3 weeks. So, for the pregnant women, it's not good to take the antibiotics.
Thank you, Leo. So pregnant women, children who are not able to swallow the capsule are not recommended for this particular test. So
yeah, exactly.
Yeah, because normally after the test is confirmed, you need to take the ESO kit for a period of time. So it may not be appropriate for that particular demography. Thank you, Leo, for that. The next question from Bosley. How do you handle false positive results? Yes, Jessie? You want to answer that, or Leo?
Mr. Leo. Yeah.
How do we enter the positive?
The false positives, because you can have false positive results. Yes.
Okay, handle. How do we handle false positive result?
Yeah.
I think if because the sensitivity and the specificity of this test are both higher than 95%, so it's the gold standards. Normally, we don't have false positive results if the operation is if the lab staff conduct the test according our instruction for use. But if we find some false positive results, maybe we can use the sample to test again.
Okay. So the sensitivity and specificity is quite high for this equipment compared to the serology or the stool sample. I think you saw it's about 85% for stool, but this one is about 96%. So the false positivity, if you get any false positive result or you suspect it's a false positive result, it's always recommended to do a retest so that you're able to confirm the same. So it should be also be able to be interpreted with the clinical aspect of this. The next question is from Kimitei. What are the current first-line diagnostic methods for H. pylori? And how is urea breath test effective compared to other non-invasive tests like stool, H. pylori antigen, and serum H. pylori antibody test? You want to handle that? I think you had already mentioned it earlier, but it's okay, you can repeat.
Could you please repeat the question?
What are the current first-line diagnostic methods for H. pylori, and how effective is urea breath test compared to stool antigen tests and serology serum antibody tests?
Okay, thanks for the question. In fact, according to the H. pylori diagnosis and treatments, there are a lot of global consensus. And we have the guidelines from the World Gastroenterology Organization. And also we have many global consensus that all recommend to do the test. Early screening and early treatment for H. pylori can reduce the risk of gastric cancer. So that is the first line guideline. And compare with other types like serology or stool antigen test. Serology test actually is the specificity is very low because it cannot identify the active infection, because even H. pylori has been eradicated, and the antibody still can be in our body for maybe years. So the blood test, the serology test, always give a false positive result. And for stool test, because the collection of the stool is distasteful, and also the storage of the stool requires the temperature between 2 to 8 centigrades. So for UBT, first is the gold standard, and the collection of the sample, also the storage of the sample, are more friendly to the labs, because for we collect the sample with the cart, and the cart can be kept at least 7 days. So it means that the labs can also collect the samples from other clinics. So it's very friendly to the lab staff and it's friendly to the patients. Yeah, that's it.
Thank you for that. Virtually, for non-invasive tests, the urea breath test is the gold standard for the testing. So H. pylori antigen and H. pylori antibody are quite inferior in terms of the sensitivity and specificity that had been highlighted earlier, Mr. Cornelius. So it is the gold standard for non-invasive tests. So invasive tests like endoscopy are quite expensive and out of reach for many patients. So the urea breath test is an alternative and a gold standard for non-invasive. So thank you for that. We have a question from Gertrude. Thank you for the good presentation. Sorry?
I wanted to add on something for the...
All right, proceed.
Yes, kindly. So there are some of the members who had joined late. So just to respond more on the query that Mr. Nelson Rotich had asked. So we'll go back to the principle of the analyzer. So on the principle, we are administering a urea labeled isotope to the patient. So that's the particular capsules that we are giving this particular patient. So remember, we have labeled that particular isotope, and then we have the analyzer, which can read detections or availability of that radioactive material in the sample. So we are either using carbon-13 or carbon-14. So depending on how the facility wants or the organization or the legal representative in a country, carbon-13 or carbon-14 can be used. So you have carbon-13 that is non-radioactive, which is very safe for adults and children. And then we have carbon-14 options that is mildly radioactive and used in some test kits. So at the end of the day, after you've swallowed the capsule, within a few hours or within a day, you find that you'll be able to excrete those particular remnants of the radioactive, and we are using the carbon-13 or carbon-14 because of half-life. So remember, any radioactive material has a half-life. So at the end of the day, you'll find that it's clearly excreted from the system. So why are we using it on H. pylori diagnosis? So this particular bacteria, H. pylori, in the stomach, they will secrete the enzyme urease. So since it's known, and that's why it's used in the principle, urease will only be produced by this, secreted by this particular H. pylori bacteria. And that's why it's also the gold standard, because interactions with other bacteria in the stomach will be limited. So let's say a healthy individual does not have H. pylori. Once they swallow the kit, no urease is produced, and essentially no detection of the urea or the ammonia and carbon dioxide in the breath. But if a patient or a client is actually infected by H. pylori, the H. pylori actively produce urease, and once urease is released, they will break down the labeled urea, that capsule that we are giving, and ammonia and carbon dioxide will be produced. So a negative patient, no ammonia or carbon dioxide is released, while a positive patient, they will be able to have urease reacting with the urea in the capsule that is labeled radioactively by either C13 or C14. And that ammonia and carbon dioxide is what now we are detecting. So once you are given that particular card to blow in, we are blowing for 3 minutes because we want to release. And you remember when Jessie was mentioning on the precautions, we need to have an empty stomach so that now the H. pylori that are active, they'll be able to now release more urea. So that's the essence of the empty stomach. And we are also avoiding the smoking because as we are a smoker, if they have smoked within the last 2 hours, the breath that is released in the card will be affected. So that's why we were mentioning those particular precautions. So now remember that labeled CO2, that carbon-13 or carbon-14 is absorbed in the bloodstream, then exhaled through the lungs. When we are doing the breath samples are collected, and after injection of the urea substrate, the analyzer will measure the ratio of the CO2 to the normal CO2. Remember when you were saying we have to put the machine and test the initial test after installation for around 40 minutes, the analyzer is just reading the environment radioactive carbon. So it calibrates itself. So when you are measuring what you have exhaled and versus the normal CO2. So that's when we have a rise of a reading of above 50, we'll say we are positive. A reading of below 40 will be recognized as a negative. So remember, above 50 can be 100, 200, depending on the amount of CO2 that has been detected on that particular breath. So I wanted to clarify on that so that you understand the principle and why we are saying that we are giving using breath, and we don't have any any samples to be collected from the patient, either serum or blood or stool. So just the swallowing of the capsule that is radioactively captured with C13 or C14 can give. So you have a machine that can do using C13 and a machine that can use C14. So depending on the facility's preference, we can be able to select either between C13 and C14. Thank you.
Thank you, Haroun, for that exhaustive explanation. So the next question is by Gertrude. Thank you for the good presentation. Why should a patient be fasting? Or are there foods that can influence the test results? If yes, if 2 hours fasting period is 2 hours fasting period sufficient? Thank you. So are there foods that can affect the results? And is the 2-hour fasting period sufficient enough?
Okay, thanks for the question. And you know, the bacteria H. pylori adheres to the gastric mucosa. So fasting 2 hours or empty stomach can make sure that the enzyme produced by H. pylori can react with the urea that the patient swallowed. So if the stomach is not emptied, maybe the capsule cannot react with the enzymes produced by H. pylori. So that's the only reason. And 2 hours is enough because I think we have do a similar study. Fasting 2 hours, the urea enzyme can react with the capsule. Yeah.
Okay. So are there foods that you need to avoid?
I mean, the requirement for fasting is to make sure the urea enzyme produced by H. pylori can react with the urea that's swallowed. If there are a lot of food, if the stomach is full, there's no space for the enzyme to react with the urea capsule.
Okay, thank you very much for that. So once the stomach is empty, at least 2 hours is enough for you to have enough allowance in the stomach for the interaction between the capsule that is swallowed and any kind of gas that is produced. So I don't think any food will be an issue here because your stomach will already be having some allowance or some emptiness at one point. So I think 2 hours, as you said, is quite sufficient enough.
Yeah, and also you find that if you are managing critical cases, the option also of fasting overnight is also acceptable as a better preference. But the minimum limit that we are allowing for you to stay without food should be within 2 hours. But if the patient or the doctor recommends an overnight fasting, is also much more preferred.
Thank you, Haroun. There is a question from Abdurrahman Subira. Thanks, Jessie. That was a good presentation. What are the limitations of the test? Are there any known side effects related to the procedure? Leah, you want to pick it up?
Sorry, I didn't get the question. Could you please repeat again?
Are there limitations of the test? And are there any known side effects related to the procedure?
Okay. There's no side effect because the only ingredients of this capsule is urea. And urea is very common in human body. And the difference of our capsule is it has been labeled carbon 14 or carbon 14, carbon 14 or carbon 13. So that's the urea only. There's no side effect. And about the limitation, I don't think there are any limitation for this test because, you know, in some countries like Japan or China, the UBT has been put in the routine medical checkup program. So every year we do this checkup with the Urea Breath Test. So I don't think there are any limitation. Yeah.
Okay. I think as a good practice nowadays in Kenya for the wellness check, I think we need to add H. pylori because if you look at the prevalence that is present in our population is also quite something that needs to be looked at. So it's some of the recommendations that even the lab team can recommend to the clinical team so that it's part and parcel of that particular process. So the other question is from Bosley. What is the incubation period after taking the drug before breathing into the gadget? Who wants to pick it up? Leo or yeah?
Sorry. Could you please repeat the question?
What is the
Hello.
incubation? Yes, Haroun.
Yes, Leo. So once you've taken the drug or the capsule, it's recommended that the patient or the client we are doing the test for sits quietly. So quietly means that they are not doing any activities, no movement. So just sitting quietly so that the urease and urea can react. So the recommended timeline is 15 minutes. If you have done a collection that is, let's say, far from the site of testing, it's always recommended to do the test within 2 hours. And in those particular tests, you will be given like a carrying bag so that you put the test card inside and it can be safely stored. So that usually just limits the exposure of that particular breath card to the environment or also loss of that particular breath in the card. So if the client is with you in the lab, they sit quietly 15 minutes, so you can just take them to the waiting area after they have swallowed. So they drink water and the capsule, sit for 15 minutes. After 15 minutes, they come into the lab, breathe into the card for 3 minutes or until the indicator card changes color, and then you can be able to testing. For home collections or faraway collections, there's a procedure for storing that particular card that we usually do, and the card can be stored for some time. And if we have not used those particular methods of storing, within 2 hours, you should be able to test. Leo, if you want to add anything?
I think you already explained very well. Thank you.
All right. Thank you for that explanation. The next question is from James Musioka. Ellen, thank you for the good presentation. Is the test specific to H. pylori or generally gastrointestinal bacteria? Lastly, when blowing the sample to the kit, you have to blow 3 continuous minutes, or is there an indicator of sufficient sample that is collected? I think what he means that is the test specific for H. pylori or any other bacteria in the stomach? And if you're to blow continuously, is there an indication of sufficient sample for the whole thing to collect, for the kit to collect, sorry?
Oh, yes. There is an indicator on the card. So the color of the indicator, if the color of the indicator changes from orange to yellow, it means that we can stop blowing. So without the indicator, also, it's not necessary to blow continuous 3 minutes. Of course, the patients can take a break, but we need to remind the patients, don't blow in, only blow out.
Okay. So this is specific to the H. pylori bacteria because the one that is able to produce the urease that we are looking at. So virtually it is not for any other bacteria, unless maybe my co-panelists want to add something. Haroun, you want to add something?
No, it's just specific for the H. pylori diagnosis. So any other gastrointestinal conditions the patient might have will require other diagnostic methods. So if they're trying to look at ulcerations, any other thing that might affect the patient or the gastrointestinal, other procedures or diagnostic procedures in the doctor's office can do. But for diagnosis of H. pylori, it's only specific to H. pylori because we are focusing on H. pylori because of that production of urease enzyme.
Okay. How much is the machine and the test? I think, Ruben, you can share with us your contact details and we'll be able to get back to you with our sales team. Okay, the next question is from Subira. Can UBT differentiate between active H. pylori infection from colonizers? Leo, you want to pick this up?
H. pylori infection from UBT can identify the active infection of H. pylori. Because if H. pylori is presenting in the stomach, it always produces the urea enzyme. And if urea enzyme is presenting in the stomach, it means H. pylori is presenting in the stomach. And with our UBT, we can identify that.
So Jessie, just to add on that or a follow-up question. So as per the understanding, let's say the patient has come on day 1 for the test and they get a reading of, let's say, 100, then after they have done the treatment. So is the results can be used to show or monitor the treatment? Will the reading from the first day of infection be higher? And on, let's say, after treatment, or during treatment, the reading can be can go low, and after the treatment, it goes down. So can it be used to monitor that particular treatment, or any reading that it can be just positive for H. pylori or negative for H. pylori? So can the readings be used? So let's say at day 1, we got a reading of 100. The other tests around 56, and then afterwards a low reading of, let's say, 30 that we say negative.
Okay. The count of the results normally reflects the activity of H. pylori. So if the result is a very big number, like hundreds, it means the activity of H. pylori. It means H. pylori is very active, produced a lot urea enzyme. But we don't recommend UBT to monitor the treatment during taking the medication. Only after taking the medication. For example, after the treatment and 1 month later, we use UBT to follow up the treatment H. pylori. Actually, the Urea Breath Test is the most recommended way to detecting to follow up the treatment.
Thank you, Leo. So that's very clear. So Subira, so if the patient has been tested on day 1 and they have been found to be H. pylori positive, so during the course of the treatment is also a precaution that the manufacturer is recommending. During the treatment procedure or process, you will not be able to test using UBT again. So don't do a test if the patient is actively on antibiotics, or if the patient is referred to you from a different facility and they were tested maybe using a different diagnostic procedure, and they come for confirmatory tests using H. pylori. So how in the demographics or the history that you'll collect from the patient, if the patient is on active antibiotic treatment, the test is not recommended. After the treatment of the patient, at least 2 weeks after is when now we can do the UBT testing. So that should also be noted when you're recommending the UBT tests. You have to inquire if the patient is on active antibiotic treatments, and if they are, you give a recommendation of at least between 2 to 3 weeks before you can do the UBT test. Thank you.
Okay, then that is well answered. There's a question from Hillary. Can UBT differentiate amoxicillin resistant H. pylori, or it's non-specific?
I'm afraid it cannot difference amoxicillin resistance. All the antibiotic resistance, we cannot use UBT to identify that.
Yeah. So, Hillary, I think for that particular case, I think now if we want to focus on resistance of a certain bacteria, we now go to the other diagnostic method where we can now get kits for PCR. So these particular PCR kits there, you'll have the antibiotic resistance detection and the different types of the antibiotic resistance, and you'll be able to detect now in case we want to focus on or testing on resistance. So that one we can go further and maybe do now PCR testing for it, for an already confirmed patient. So you've done the UBT, you've confirmed that it's positive, and maybe the doctor, the patient has maybe been on treatment, because if the patient has never done the antibiotic treatment, it will be okay for you to now start the antibiotic treatment. But now the gastroenterologist says the patient has been on active medication and we want to check resistance. Now we can recommend PCR kits for that, and we also have that particular available. So if you have a PCR lab, you can be able to offer those particular kits as well.
Rono, you want to ask a question? I can see you're muted. All right. We have a question from Mora Mary. If a patient has a high blood urea result, can the test still be done?
Yeah, I think no problem.
Yeah, I think
Yeah,
maybe.
sure, we can do that. Yeah, yeah, sure, we can do that test.
Okay. From Stephen. Thank you for the presentation, excellent presentation today. It was clear. Haroun, can you mute Rono? Okay, I've disabled the mic. Okay. From Stephen, thank you for the presentation. It was clear, engaging, and very informative. I truly appreciate the effort you put into it. Thank you very much, Stephen, for the thumbs up. Titus, is there a method? Sorry?
Just to elaborate on Mary Mora's query.
Okay.
So yes, it will not affect if the patient has high blood urea results. The test can still be done, as Leo said. But now remember, if your patient has taken the capsule and you've done the test for H. pylori UBT, and then the same patient has been requested for tests in the chemistry lab for urea. Remember that particular urease and the releasing, they will be absorbed in the bloodstream and then now released through the lungs. So remember, after that, you need to give, the patient needs to take some time before you now do that particular urea test in the chemistry department. So within a few hours, now you can be able, so that you don't have also an issue of highly urea results interferences.
Excuse me, I'd like to add on. The reason I said the patients with high blood urea can do the UBT test is because for the test, the dose of the capsule is very small, very tiny. When we open the capsule, we can see nothing because the dose is very, very small. And so it will affect the blood urea. Yeah.
Thank you, Leo.
Okay. Timothy is saying, is this method suitable for follow-up testing?
Oh yeah, of course. It's the most recommended way to follow up testing. Follow up testing or follow up treatment?
I think follow-up testing after treatment.
Yes.
So
Yes.
yeah, when somebody is found to be H. pylori positive with this method, and then they're put on treatment, is it still recommended for the follow-up testing? I think that's what Timothy means.
Yeah, this is UBT is the most recommended way for following up the treatment.
Okay. Thank you for that. I bet we have exhausted all the questions on the chat box, unless there's any other questions on any area.
No.
Let me just see. Okay.
Questions have been exhausted. So anyone else who has maybe a comment, they can be able to unmute and comment. We still have 14 minutes to go.
Let me check them. There are more
Yes,
questions
on the chat box.
Okay. So John Chomber, how will you distinguish your analyzer from others to avoid counterfeit? Okay.
In fact, our UBT is a closed system, so our kit can only work with our analyzer, and we never saw any faults or similar products like ours.
Yes, so also just to address maybe the lab's concern from an applications on service point of view. So the analyzer, as you've seen from that particular image, is a very small analyzer, a benchtop analyzer. So during installations, the only thing we require is that you have to be in an environment that is less affected by radioactive material. So let's say if your lab is near the X-ray room, that's not a recommendation. So usually should be in a very good setup, and installation is very direct. Once you have the analyzer on your lab, you just we do that particular background testings on the initial installation for around 40 minutes. We do the QC checks. We have 2 cards that we do that check with, and you'll be recommended to do the test within a certain duration. So you don't need any external reagents or consumables to work with it, only that particular card. The particular cards you usually do the, it will be like the calibration point, because we are measuring the carbon released with the particular kit and also the background. So that one is usually very important for us to achieve the background of that particular environment. So if you are in a setting where the machine is moving from the lab and is taken to maybe the gastroenterologist center, or for at a different location, you ensure that that particular machine is also done that particular test for 40 minutes to take care of the environment, radioactive elements within that particular environment. And then the only consumable you need to buy is those particular kits. The standard cards come with the machine during the first installation, and they are suitable for a duration of up to around 5 years. After that is when now we change. We don't need any external reagents or calibrators for that particular method. So being a gold standard with very high specificity and sensitivity, it's a very good unit to use. So the major part of the training will be just to use. We have only a few keys on the screen for you to operate, and just to know how to insert the card. So there's a procedure to insert the card that has to be accurate, and that's the only important method that we do. Being maintenance free, the only thing we do is just cleaning the surface. It doesn't have any cumbersome procedures for you to handle. And certain procedures are maybe done every month, or if the analyzer has been moved. So the main part of the training will for you will be how to instruct the patients on how to do that particular test. So giving the patients the instructions and checking on how the patient is doing that particular breath with them to ensure that they are blowing into the card and not sucking back the air from the card that they have blown. So it's a very easy to use equipment with no additional costs of consumables, containers, syringes, and anything else.
Okay. Thank you. We have from Hillary. Thanks for the nice presentation. What happens to patients who are using medications like antiflatulants, like omeprazole, or antacids like gastrogel? Will it affect the testing as well as when they are not actively on H. pylori treatment?
Okay. We recommend patients stop taking PPI for 2 weeks and antibiotics and bismuth for 1 month before doing this test, because the medications will inhibit the activities of H. pylori.
Yes. So virtually those particular interferences will affect the results. So those are some of the instructions that you need to find out from the patient if they're on any of those. So any other questions? I think I'm exhausted. I've exhausted the questions on the chat box. So Bosley, go ahead. Unmute your microphone and ask your question.
Thank you so much for that. My worry is now in regards to the question, to the answer that has been given, that in case a patient is on medication, you need to stop for 1 month. So that means this is a screening, because if a patient is on medication, has been prescribed to be on medication, maybe in a continuous 1 or 2 months, stopping it can worsen the situation, my feeling. So does it mean this is specifically for screening, not for diagnostic? So diagnostic and ensuring that the results are active. So for those who are on medication, so does it mean that we don't subject the kit to them? Thank you.
Mostly, I will respond in this way. So we have said the PPIs, you'll stop taking it for 2 weeks. So those antiflatulents and so on. And then if the patient is on active antibiotic treatment, it means either before they come to your lab, they may have been tested using a different method or somewhere else, or they were tested on the UBT and they were confirmed that they were positive. So the doctor has recommended they start treatment. So during the treatment process, you will not be able to test, because you have already confirmed that maybe this particular patient, using the diagnostic tools that you use, you have already confirmed that this patient is on active treatment and they have been confirmed positive. So within the treatment procedure, you don't subject this test to the patient. Why? We have said that the H. pylori has now been is now being hindered. So when you have swallowed that particular capsule, the medication is actually fighting off that particular H. pylori. So they will not be actively producing that particular urease, depending on how the medication is working. So by that particular process, if the H. pylori has been hindered to actually do that, you'll get a result that is not very accurate. So after the patient has finished the medication, either between, if they have taken for 2 weeks, you'll wait for 1 month. After the 1 month, now you do the test. So this test that you will be doing after 1 month is a follow-up test to confirm if the patient had now been cured of the disease and they are now negative. So that's the follow-up. And if you still find it as positive, now you get to query, was the medication that the patient was given effective, or now you want to check the on PCR, you want to detect the resistance to a certain medication that maybe you have given. So that's the only recommendation. So if the patient has now on active treatment, wait for that particular 1 month, then do the test. You'll either get positive or negative depending on if the medication has worked. So that's the follow-up question. But for this particular PPIs, it's just the recommendation is at least 2 weeks. They stop that so that now you do a test. So remember that the patient might be having those PPIs depending on whichever gastrointestinal issues they were having and what the doctor was recommending. If it was a properly medicated procedure or they have been on active treatment. So that particular test will now be done for follow-up. So it can be used during screening for patients who have just walked in with certain issues, and then maybe the doctor recommends screen if the patient has H. pylori, and can also be used during follow-up after the treatment has been done. And the recommendation is you wait that duration, because during active treatment, the H. pylori bacteria are being affected. So you won't get the urea being released effectively, and that part will interfere with the results that you are getting.
Thank you, Haroun, for the exhaustive explanation. So I think mostly when you are on medication, I don't think you need to do a test because you've already known what you're suffering from. So maybe after completing the medication is when you can be able to do the test to check whether the whole thing has been eradicated. Anybody else, you can feel free to unmute your microphone. We have only 4 minutes, the top of the hour. I don't think I have any other questions on the chat box. Anybody else? So if there's no any further questions, on our marketplace, we have the equipment with us and also the kits. I think the uptake in the Ugandan market has been very good. I think they are the early adopters of these technologies. So Uganda has been on this technology for the last 8 years. They're just our neighbors. We're introducing the Urea Breath Test technology in Kenya, and I think we're not so late as well. We should be able to augment the same to help us in diagnosing H. pylori. I think H. pylori has been something that has been quite difficult to diagnose because of the false positives we have with all manner of kits in the market. So if you're able to, if you want the gold standard for the non-invasive technique for diagnosing H. pylori, I think you can reach out to us. Our numbers are there. We'll also reach out to the guys who have shown interest. We'll also be available on during a Kamulso conference, so that if you're attending a Kamulso conference, we'll be able to give you, and you'll also be able to feel the touch of the equipment and also the demonstration. So Kamulso is there I think in October in Mombasa. So you'll be there to also ask you a few questions here and there. So in case there's no any other further question, I'll hand this back over to Haroun, who is the organizer, and also will be able to thank our presenters. Over to you, Haroun.
All right. Thank you, Antony, for conducting the event. Thank you to our presenters for today, Leo and Jessie. So thank you to the participants for attending the webinar. I will be able to share the recording via our YouTube channel for your further reference in case you missed the first part of the session. And also we'll be able to process your CPD points for registered participants. So thank you so much for attending. To close, I'll give it to Leo for closing remarks, and Jessie, our presenter for today. Thank you for a wonderful presentation, and looking forward to more interactions with with you and our participants. Over to you, Leo.
Okay, thank you. On behalf of Headway Company, I'd like to express our sincere gratitude for your participations on this webinar. And by this webinar, we hope to share some information about H. pylori and UBT to deliver a good gold standard and practical products in Kenya. In fact, this technology has been widely used in many countries. Hope in Kenya we are going to have this technology very soon. And thanks for all the doctors and our partner Keton Fellows. Thank you.
All right. Thank you very much, Leo, for the wonderful session, and we appreciate you. And,
Last comments from Jessie.
Thank you for taking the time to attend today's CME. I appreciate that this chance to present our product as a presenter is my honor. Thank you.
All right, Antony, you can close. Thank you.
all right. Thank you, everyone, for the opportunity to continuously impact knowledge as a team. So we believe a lot in knowledge sharing as Keton family. So always stay tuned every Thursday on for our webinars. This was our 8th in series. We've done the last 7 for the last since this particular series became active. So next week we'll be able to also to handle another topic. So we'll be able to share with you on the WhatsApp group so that you are able to join. So for today it was a free webinar, and Haroun will be able to process the certificates and also award the CPDs. So thank you and have a good day.
Thank you, Antony. Charles Mwanzia, thank you, Keton Group, for putting up the link on the board site. You're welcome. Samuel Odrol, thank you for the wonderful presentation. So as always, you can always review the topics that are on webinar series on your KMLTTB portal. So just scroll to the tab indicating scheduled events, and you'll be able to see the active or scheduled presentations. And for Keton Consulting, we'll be sharing the link on that particular site as well. So it's good feedback that someone has benefited from that. So you can always get a link from our WhatsApp link or the board's your KMLTTB account portal. You can be able to monitor the CMEs that are being posted. So otherwise, thank you. For anyone who has not joined our group, we'll share the WhatsApp link invite on the chat box. So anyone who wishes to join, they can be able to do so using that particular link. So thank you so much for attending, and I wish you a good day. See you next week on another series. And thank you to Leo and Jessie for the wonderful presentation. I think everyone here has really benefited, and they have learned a new thing. Thank you so much, and bye-bye.
Bye-bye. Thank you. Have a good day.
Bye-bye. Have a good day.
Have a good day as well.